All right, let me just make sure. Okay. Welcome to another educational blog. My name is Manny, and as usual, I just want to share some concepts, or if you're looking for like an ICU training, and for those who are following me, so welcome back. Today we're just gonna discuss about cardiovascular related disorders. In the ICU, right, there's a lot of cardiovascular issues, and over the years, guys, I'm not trying to be mean, but I have seen how, and it's the reality, nurses are struggling with some of the cardiovascular disorders. And do I blame them? No. Who do I need to blame? The hospital, right? No one to blame, but I guess it's because we all have accountability. My accountability when I was a new nurse is to learn how to take care of a patient and to pretty much understand why the doctor orders certain medication, right? Or why are we doing it that way? So the Institute of Medicine, IOM, is now known as the Academy of Medicine. They highly encourage that the nurses should at least further their education and training. So that means you're no longer just settled for bachelor, right? So if you're AD, you go to BSN. And if you're BSN, you take your master's. And if you're master's, you take your doctorate. So I did that. So BSN to master's to doctorate. And over the years, you develop that mastery on what you do. There's an advantage and there's a disadvantage. So the advantage is you're growing, you're getting better. The disadvantage is sometimes you become more critical, especially if the new doctors, because let's face it, when I was new, so the old seasoned doctors will tell us, stupid, why are you working in the ICU if you don't know anything, right? Because we're so new. So that really challenged me to study more and learn more and continues to experience a lot of things, those kind of things. So I did not stop, to tell you guys honestly. I pretty much I asked the doctor, hey, why are you ordering that? This kind of thing. So this is just an introductory of what I'm trying to say. There's a lot of frustrations out there, and I know that it's not your fault. You don't know what you don't know. We call that a conscious incompetence. But what really scary is the unconscious incompetence. You don't know that you don't know it. That is scary because you're doing it and without knowing that it's wrong, right? So just be careful, guys. Okay, so we're gonna talk about how are you going to assess the cardiovascular system, which is your heart, right? And then there will be pharmacology, hemodynamics, acute coronary syndrome, some of the management like cardiac cath, open heart, right, impella, those kind of things, and then severe heart condition, heart failure, and cardiomyopathy. So we'll see if we can squeeze all this, but my goal here is not to make you feel bad. I know sometimes being an ICU nurse, you need to be upfront, right? So I think that has been my personality, being an ICU nurse. I say it sometimes I tend to be more cautious on what I say so that I won't offend anybody. But just train yourself to be accepting, right? Flex, understanding, your level of sensitivity, make it a little bit more higher. So if you don't know, admit you don't know, and then you learn from it. Okay. What do I say? 33 years of being an ICU nurse, 3 decades, OMG, right? So I have seen from the changing landscape here in the United States, changing landscape of healthcare. Many years ago, if you have an MI, we will never touch you. We will not gonna turn you, because they were thinking, oh, increase oxygen demand, but decrease oxygen supply, right? So nowadays it's no longer true. What we're doing is door to balloon. We need to take you to cath lab and open those, blockage, or we take you to OR and do a cabbage, things like that. And also, before you put your patient on the Trendelenburg, if they're hypotensive, nowadays we don't do that anymore. You just put them flat, or you do PLR, passive leg raise. So why am I sharing this? It is because if you don't know and nobody told you, because when I was a preceptor, I'm very, very good at sharing information, but nowadays I felt like I don't have time, girl. They don't share information anymore. So, and then of course, poor new nurse, he did not or she did not know what she did not know, and then the expectations, oh, your managers, your educator, and some of the educators nowadays, guys, no offense to the educator, they will take this job without experience, and they will just teach by what they read or watch on YouTube. No, not good. I highly recommend to really work on your bedside in order to become a good educator, right? Because it's different from what you read on the book and what you do at the bedside. It's completely different. I'm just saying. But they love that job because they can just come whatever hours they want. They can go home. They can walk with their coffee. And how are you? Go to the station and just say hi, and then they're gone. You don't see them anymore. You don't even know what's, what are they doing, right? So these things like that. Hopefully your educator, ICU educator, is good, because they are very important. They're supposed to be guiding you at the bedside. They're supposed to be doing an inter-rated reliability, meaning they're checking you off, they're looking at it and confirming what you're doing is correct. They should be change agent, right? So they're promoting some best practices out there, at the same time watching you, how you implement that at the bedside. Because it's not just about classroom or sim lab, it is how you do it at the bedside. So my nurse educator before, many years ago, our nurse educator, they're just in the nurse station. They're watching us. And then you can grab them. If you don't know anything about the PA catheter, then they teach you real time, those kind of things. Nowadays, I don't see them anymore. Kudos to those nurse educators that are seasoned nurse educator that are really helping staff nurses. So my goal here again is just to present reality, not to terrorize good and bad educators. I'm just giving you time to reflect and sharing all these things that we see at the bedside. Okay, because I've been doing a lot of bedside since 1991, and if you've only been a nurse for 2 years, probably you haven't seen it all, right? So in order for you to become a good educator, you need to have a lot of years of experience. So why? Let's just say I'm working in one hospital where we don't do a lot, right? When would you experience balloon pump if you're not a CV ICU? When would you experience EVD ICP monitoring when you don't have neuro ICU? Those kind of things. So I know a lot of us are working two jobs, So I did that too many years. So I went to my neuro ICU, and then my other job is CV ICU, right? And then after that, I pick up somewhere like a general ICU. So it really is important to have different experience, and because your experience makes you really a good nurse. Okay, how do you obtain accurate data? I always ask this, to myself. First thing I do is, once you get a report from the oncoming shift, make sure you zeroed your PA catheter, right? Art line, Swan Gans. I don't use Swan Gans anymore. I call it PA catheter because that's just an old name. Swan, Dr. Swan and Dr. Gans. I think they already sold this to Edwards, so it's PA catheter now. Edwards Life Sciences. So what you do is you zeroed your source of hemodynamics, right? Either PA catheter, either just an art line, so that you will you trust those numbers. Anything like, just in case you're passing and then the alarm, you know that you calibrated those and you zeroed those, and those are real. Because what did I see? Oh, is that real? Now you're wasting so much time, right? It's real because you know that you calibrated it at the beginning of your shift, unless you move the bed, right? Or unless somebody kind of just did something and then they forgot to recalibrate it again. So that is what I said, accurate data. Blood pressure cuff, I've seen them in here. Is that accurate? No. I've seen them in their legs. Is that accurate? No. And then you're giving them a lot of multiple drips. Levophed, right? Dopamine, dobutamine, and vasopressin, and then they're just taking it from blood pressure cuff, and it's in the legs or it's in here. So not a good practice. I don't know about you guys, but what I normally do is, some of the doctors likes to put an art line. I ask them. Some hospitals in their policy, respiratory therapists putting an art line. Well, if that's your policy, why not, right? If they're competent, why not? You have a nurse practitioner, nurse intensivist, then let them put an art line. It's important that you have an accurate data. You are either over treating or under treating your patient. Okay. Physical examination and understanding of the anatomy and physiology of the cardiovascular system is really important. So my preceptor many years ago said, and even the cardiologist that I work, the heart is not facing this way. So if this is your heart, it's actually, this is just the side, the right side, and this is the anterior aspect. So it's tilted to the left like this. Why? Whoever invented us is really smart, because if I hit a steering wheel, the first thing that's going to happen with the rib cage and my heart is damaging or infarcting my right side of the heart, right atria, right ventricle, which is fine because it's just a receiving chamber, and the left side, which is a pumping, is actually tucked in, right? So that is what I was asking you guys to understand. Sometimes the heart is dextrocardia. It's facing the other side. So when I was a new nurse, guys, you put your stethoscope, right? And I was listening, and I don't hear the lub-dub here. It's supposed to be on the right? Mid-clavicular, on the left side, right? And then you're supposed to hear lub-dub, lub-dub, lub-dub. So I was like, I'm not hearing anything. I'm just hearing breath sounds. So when I put my stethoscope on the other side, that's where I heard her lub-dub, lub-dub, lub-dub. And then I laughed. And then I said, hey, I'm not sure what's going on. I said, but I'm hearing your heart rhythm sounds, heart sounds on the right side. And then the patient said, you're correct. Because my doctor told me that when I have this, like my heart is not on the normal side, but it's on the other side. So it's dextrocardia. And then she said, you're the only nurse who actually told me that, and you are completely correct. and she said, I wonder what the other nurses are putting on my chart. So that is just me being honest, because I do the right thing. Okay, so please do the right thing. You are a nurse, you're a registered nurse, and then you do your assessment, right? Your pulses, feel for the pulse. So is it bounding? Is it you feel it and then it's gone, you feel it again and it's gone, pulsus alternans, right? Or pulsus paradoxus, those kind of things. Please use a very good stethoscope, not the yellow one, not the cheap one like the isolation stethoscope, because what you hear there will all diminish, right? It's not a good instrument to assess heart sounds. And then you analyze your waveforms. So your CBP, you need to manually analyze that, guys. I'm not sure if you guys are aware, but hold on, let me just explain it. So so A, C, V, right? So this is your A, this is your C, this is your V, X, Y. Y and X descent, X, Y, Z. X descent and Y descent. So you should be manually printing your CBP and then measuring them and get the mean. Okay, so again, use your nurse educator. If you haven't really done so, you don't know what's CBP trace, then you really have to know that. So there is this line on the EKG. Let's just say 0 to 4, right? Let's just say that. So the peak is the 4, and then the this one is the 2. So between 4 and 1, so that will be your mean. So the middle. So but at least I would probably say this is going to be at least 2, 2.5 your CBP, if that is what you measured. Okay, why? Because your monitor is not 100% accurate unless your biomed is they are calibrating, you're checking your monitor every year, and then your green sticker is good, right? Because sometimes those monitors can also fail over the years, over the months that it's been used, and then there's a lot of I don't know, if they're not being recalibrated or re-inspected by biomed, then don't trust it. So I would say I still manually calculate my waveforms and then compare them to your numbers on the monitor before you accept your documentation, right? Because it will interface into your electronic healthcare record. And then make sure when you are with your vital signs and hemodynamics, just don't enter. Check the whole numbers, because I have seen nurses respiratory 32, and she entered and she saved it like that. So if you got into a situation where this patient is gonna sue the hospital and you're one of the nurses, then how would you explain that to the lawyer, right? I'm just saying, guys. I'm just being true. A lot of these new nurses nowadays, and nothing against new nurses, because this is what I observe. I love the new nurses because they're so interested and eager to learn, but then the other nurses don't want to teach because they just mind their own business, right? And then here comes the baby boomers, the very strict nurses, watching them like a hawk. They would give them more comments if they're on their cell phone all the time. So I don't know, I just noticed that is the diversity now at work, right? We're not just diverse with race, but we are very diverse with age and sexual preferences too. All right, So, and then you interpret and integrate that data, and then your clinical examination findings. So you should know the normal from the abnormal, or abnormal from the normal. So mental status. Are they alert? Are they oriented? Are they following commands? Things like that. Urine output. So again, your urine output, you need to check it. I normally like to check the the amount, the color, and the consistency. Right? Do they have sediments? Things like that. Edema. You have to check for their edema. So basically, you have to do your head-to-toe assessment. Cap refill, jugular venous distension, right? So as an ICU nurse, you need to assess all those. So I think we all talk about your anatomy and physiology of the heart. So as I've said, if this is my right coronary artery, I am feeding the right side of the heart, right? So the right atrium, right ventricle, and then at the bottom, posterior aspect to the back. So inferior, posterior. Okay, so that's your right coronary artery. Right coronary artery. So if you're getting a patient with, they said, hey Manny, you're getting an MI from ED. Okay, then posterior MI, that's right coronary. Inferior MI, that's right coronary, right? Well, are those an emergency thing? Well, they're just in the receiving chamber. So sometimes, they will fast track them or triage them in the ED, but sometimes, they're okay. They end up being stable. They go to cath lab, and after that, you get them into your unit. And then the left coronary is like this. So right coronary, left coronary. So what's in the left coronary? Anterior, right? So the front of the heart. Lateral, the side of the heart. Septal, the upper portion of the heart. So if you're getting a septal MI, that's left coronary artery. So it's the left side. It's the pumping. So if you don't have enough blood supply to the myocardium, then it will die, the penumbra, and then of course there's some more contractility, right? So it's really important that these patients are from ED to cath lab. The 60-minute door to balloon, it's really important. Septal MI, anterior MI, and the lateral MI, or the anterolateral MI. So if you combine that is really a big portion of the heart where you're gonna damage. So just FYI, right coronary, posterior and inferior MI, left coronary, septal, anterior, lateral MI. Okay? And then of course, within the anatomy of the heart, you have your right atria, right ventricle, right? So blood from the inferior and superior vena cava, inferior vena cava, they're all gonna dump into the right atrium, and then they go to the right ventricle, passing the tricuspid valve, right? Right RT, right ventricle, right atria, tricuspid valve, and then it goes into the pulmonary artery, passing the pulmonic valve outside to the lungs, and then you get gas exchange, getting oxygenated blood going back to the left atria, right? Passing to left is L, passing to the mitral, LM, mitral valve opens up, dump into the left ventricle, and it goes to the aortic valves, open into the aorta to the systemic circulation. Okay, so if you don't understand that, review it again, because it's really important that you understand this, because it really matters when you're thinking about hemodynamics, right? Where is that blood going? So superior vena cava, inferior vena cava, this sits into that area. That's your CVP, right? Central venous pressure, if you put a catheter, PA catheter. And then the right atrial pressure, there is a pressure there too. Right ventricular pressure, there's a pressure there too. So all the chambers of the heart have the same, have pressure that, you know, the catheter is monitoring. All right, we're gonna discuss that during hemodynamics. So I think I told you about the coronary arteries already, right? So cardiac output is the amount of blood pumped by the ventricle. So I just want you guys to understand that your stroke volume and your heart rate. So stroke volume is, there are two things that I want you to understand. So let's just say I have two glasses here. So the blood that's going to fill the glass or the chamber is what we call end diastolic volume, right? So after I filled up the ventricle or the atrial or ventricle, that is your end diastolic volume. So that is, let's just say 120. And then when the heart squeezes out, right? So that is your end systolic volume. So your end systolic volume is how much blood left at the end of the contraction. So you minus this. So 120, let's just say there's 50 ml of blood left when the ventricles squeeze the blood out. So this is now you considered as your stroke volume. So 120 minus 50 is 70, right? So as we said, heart rate times stroke volume. Sometimes they say, well, Manny, I don't have any PA catheter. How do I know the cardiac output? Yeah, get your echo report. So the echocardiogram, look at the, if it was just done like this morning, check that out. Get your stroke volume in there, because your technician is measuring that, right? When the left ventricle filled up blood, she will pause the monitor and then she'll measure, and that is the stretch. So that is what they're measuring. And then when it squeezes out, the contract, she'll freeze the monitor again, and then she will measure. So that is your end diastolic volume minus your end systolic volume, and then that is your considered stroke volume. So if your heart rate is 70, right, times 70, so you have 4,900, that is almost 5 liters of blood. So 4,900 liters, so 4.9, almost 5 liters. The normal is 4 to 8 liters, right? So don't forget that. So I always say, I don't have a PA catheter, but I know the cardiac output by just looking at the echocardiogram, echo report. Okay, and then how do I know the ejection fraction? Oh my God, Manny, really? Do I need to know that? Of course, you're an ICU nurse. You should know this. So stroke volume, right, which is your 70, you divide it by your end diastolic volume, which is your 120. So if, let's say, I am having my calculator here, and who said that nursing don't have any math? God, you guys are wrong. There's a lot of mathematics in nursing. So 70 divided by 120 is 58%. Your EF then is 58%, because this is 0.58. So that is considered 58%. See, is that good? Yeah, more than 50%, right? So by just knowing this, you already know. You empowered yourself. Call the doctor. Hey doc, are you okay with this guy? It's like, what's going on? Blood pressure is really low. It looks like his cardiac output is 3.2 if you did your measurement. Probably he will be amazed. How did you get that? You don't have any PA catheter, right? Just looking at your echocardiogram. from when I explain that to the nurses, because what I do, guys, I don't share a lot of information, especially to the nurse intensivists. When I said nurse intensivists that know it all, because we have a lot of I call it KIA, KIA, know it all. So the KIA nurses, so if you are a KIA nurse, a lot of the seasoned nurses probably they're not gonna help you. So my advice is to really keep your pride really low and be open. Don't be arrogant, don't be so condescending, because they will share that with you. So I had this nurse who actually asked me, "Hey Manny," he said, how do you get this again? So I shared that to him, and I was able to, and he was able to get it. And then he realized, oh shoot, you're right. And of course, everybody Googles everything right now, right? So at first, probably he didn't believe me, and he Googles it, and then he found it. Well, sometimes it's really hard to find those information, but then I'm okay with that, guys. It's for free. Just ask me. So just how you empower your colleague. Okay. All right. What did I miss there? So your cardiac index is based on your BSA, body surface area. So again, cardiac output index for differences in the body size. I use cardiac index more than cardiac output. So let's just say cardiac index is 2.5 and above. So if my cardiac index is 2.4, I'll jump right away. I'll check the patient, what's going on, right? If you have your monitor, your hemosphere, it will tell you. And if you do your hemocalc on your monitor, it will tell you your cardiac index. So pay attention to the cardiac index more than the cardiac output, because again, it all depends on how big and how small your patient. And then call the doctor or do something, assess first before calling the doctor, okay? So AACN, the American Association of Critical Care Nurses, actually highly recommends that if your cardiac index are going down slowly, there will be subtle changes that you probably would not think that something is going on. But if you're a very experienced nurse, you know something is going on with your patient, right? So slight confusion, slight oxygenation, desaturation, those kind of things. Restlessness, respiratory rate going up, those are an indicator that something is not right with your patient. Hopefully you can calculate your cardiac index and then reassess your patient, because you do not want these things to get worse, right? So many years ago, we used to have this per diem nurse, and then she will come and say, am I the only one who's working really hard here? And we say, well, because she will code all the time. She did not know that once you are coding your patient, that's bad. That's not good. Because before you coded your patient, something is already boiling and something is already going on, right? So then the doctor said, well, the nurses here don't code because they already assess things and intervene before it become worse. And you are the one who get all this code because you were just seeing them towards the end, right? I don't know. Well, I kind of agree, because this nurse will just sit around. She will only get up when there's an alarm, and that's not good. So that's why she's always busy coding her patient. And then I said, I don't like that nurse, because she will only find out that something is wrong with me if I'm coding. Like blood pressure is low, altered mental state, I'm not waking up, my urine is completely dry, things like that. So she's seeing you or the patient towards the end, which is very poor assessment, right? And critical thinking. Oh, I love you guys. I'm not being mean. I'm just being transparent, and I'm just being true, because we've seen those, right? We've seen those nurses. And if you are that nurse that you're just coding your patient, you need to improve your assessment. Do something. As soon as you get there, you need to, that's why it's 1-to-1 or they're 2-to-1, because your assessment is supposed to be every 5 minutes. You just don't sit around. You have to assess your patient. Things can change in even a minute, 2 minutes, right? So especially if your patient is very unstable. So we talk about this ejection fraction. So your afterload, I don't know, but a lot of the nurses nowadays said, oh, do I need to know that? I am a assistant nurse, so I need to know this. I don't know about you guys, what you learn in school, but it's not going away. A lot of the young doctors nowadays, they love to float PA catheter. They love technology, right? It used to be, some of the doctors before, they said, oh, I don't want to do that because it has more side effects, complication, more than helping the patient. But nowadays the doctors are young, they like technology, connected to the monitor, to the hemisphere, and now with the AI coming, they use all this data to track and trends. So there you go, it's back again. So if you're struggling with your hemodynamics, I don't know if this is something that's gonna help you, but I'll share something. So the afterload is the pressure against which the ventricle must pump. So your TPR, total peripheral resistance. Okay, what is the arterial tone out there? Okay, what's your preload? The volume of blood in the ventricle at the end of the diastole, right? Or the diastolic and the diastolic and diastolic volume. And it determines the stress on the myofibrils. We call it your Frank-Starling law. Okay, and then your contractility is the squeeze, the force and velocity of the ejection of blood from the ventricle, independent of preload and afterload. So I'm not really so sure the majority of my viewers, if they are Asian nurses, like Filipino nurses. Hey, I'm a Filipino nurse, and the education in the Philippines is completely different from the United States. But I think because when I came here, technically I just learned the machine, but the principles, we learned it in nursing school. And then when I was teaching nursing here, I only have 1 hour to teach med-surg, and I was like, that's not enough, right? So that's why they don't focus on critical care. And you only get the critical care training when you enter the ICU, which I did in the Philippines. My post-grad training program, it was in the ICU, so ICU training post-grad. And when I came to the States, we have clinical nurse specialist and we have the nurse educator. Oh my God, they have so much time to teach because now we don't know who's gonna teach. Is it the CNS or is it the nurse educator? But they work together, and they were teaching me all this. They were teaching us all this advanced hemodynamics. Kudos to Magda Bunoy. Magda Bunoy, she, oh my gosh, she's the Filipina who worked with Dr. Swan and Dr. Gans at Cedar Sinai. She's very good at teaching us on really the PA catheter, the traditional way, right? So we'll put ice into the ice bucket, and then you put your tubings in there, so that when you're aspirating the saline is in there, and then it's cold, and then the thermostat, things like that. So it was actually a very good experience of me doing hemodynamics, real hemodynamics, right? And dissecting it and having a deep dive into understanding all those hemodynamics parameters. So if you ask me, guys, I completely understand it. So if you ask me now, what is pulmonary vascular resistance, right? So when you think about pulmonary vascular resistance, your pulmonary artery mean minus your PaOP, you divide it by your cardiac output, and that is your pulmonary vascular resistance. You then multiply by 80, that gives you the PBR in Dynes unit, right? So I don't even memorize those, I just understood how it is. And then your systemic vascular resistance is your mean arterial pressure, because that's the force of blood that came out, right? Minus your CBP, because that's towards the end, divided by your cardiac output, and you multiply it by 80. So that is what I learned over the years. So I'm not very technical using, so that's why I still manually calculate it my own, and then I will reconfirm it with the machine if I'm too close. Okay, so again, guys, this is what you get from being a nurse, ICU nurse for 33 years. You develop that mastery. So I kind of argue with the younger doctors now, because you know, sometimes they're just coming in so arrogant that know it all, like the Kia. The Kia doctors are the young ones, but they don't know anything. Trust me, guys. You better watch them so that you will correct them if they're making an error at the bedside. And then they will be like touching all your lines as if they know it, and then they mess it up. So that's why I said, excuse me, doc, what do you need? Let me help you. But if they're seasoned doctors, of course, they know their stuff. You know, the cardiothoracic surgeon are very good. But if they've only been a cardiothoracic surgeon for a year, I still watch them. I don't trust too much because I don't want to see them in court. You know, if something happens to your patient, nurses gets to be subpoena, and they will ask you questions, and I don't like to do that. So might as well just take care of the situation right there, right? And be assertive. Be assertive. Don't trust them too much, as if, you know, same way they don't trust us. Some doctors don't trust the nurses, but our doctors really, really good. So kudos to some of the cardiothoracic surgeons that I used to work at the bedside. Again, guys, I'm just saying the reality of what we do. If you're not sure, always grab somebody like your charge nurse. If you're doing your hemodynamics, grab someone if you're not sure, because there's a lot of lines, right? There's a lot of things going on. There's a lot of things that you press, especially if you're new in the ICU. Please don't do it alone. Grab someone to do it with you. So this is your PA catheter. There's a lot of different types of PA catheter, from simple to very complex, right? So you have your SVO2 here. You have your kind of like the pacemaker and CBP, transducer, those kind of things. All right. So I want you guys to understand this. This is an introduction to your hemodynamics. As I have mentioned, the blue pipeline are your venous, and then the red ones are your arterial lines, right? Arterial, or the arteries. So blood from the upper and the lower will go to the right side, right atria, go to the right ventricle. As I mentioned, it passes through the tricuspid valve, right? And then it goes to the pulmonic valve, to the pulmonary artery, to the lungs, and then it comes back. So what we learned is the blood will then become 100% saturated, right? That's true, because especially a healthy individual. And you know, you have to understand the tetra, right? The how hemoglobin, tetramer, and then there is a ferrous sulfate in the middle to make the heme and globin. And when they go into the pulmonary artery, they have the oxygen saturation in there, like how much saturated they are with oxygen. And then you learn the train, right? Like there's 4-seaters train, but they'll only pick up 1 passenger, especially if your tissue didn't really use so much oxygen, right? I don't know if you understand what I'm talking about, but that is in sepsis. And we learned that, so it will take 1 passenger and then it comes out, right? And then there is 100% oxygenated blood. However, what I was trying to tell you guys is there's a physiologic shunt. I don't know how many of you heard about physiologic shunt. So physiologic shunt means, physiologic shunt. So that means this 100%, when they will go down into the pulmonary veins, they will decrease to about 95%. There's a mixture of unoxygenated blood into the oxygenated blood. And then the question is, where is that blood coming from? Where is that unoxygenated blood coming from? Right? So that's a good critical thinking. So remember your heart, you have your bronchial artery, right? So it's here. There's a bronchial artery into the aorta, that goes into the bronchial tree of the lungs, right? The pulmonary system. So once that bronchial artery, blood from the bronchial artery, then supply the bronchial tree, the unoxygenated blood then will drain into the venous system, which is your pulmonary vein. So that is the mixture. That's where the unoxygenated blood is coming from, number 1. Okay, then it get mixed with this oxygenated blood. Then that is it drops into the saturation to like 98, 95. We call it physiologic shunt. And then the blood will go into the left atria, to the left ventricle, right? And then there's another physiologic shunt happening in there, because the blood that goes to the right coronary, left coronary artery, and then feed the myocardium with oxygenated blood, then eventually become unoxygenated blood. It will drain into your division vein inside the heart, and then into the ventricle, right? So again, that is a mixture of your unoxygenated blood. So there's 3 sources, but the other one is on during fetus. But so I'm not gonna go there because we're not pediatric, right? Or we're not near, we're not small kids, but we're adults. So from the bronchial artery, feeding the bronchial tree, from the coronary arteries, feeding the myocardium. Those are the sources of your unoxygenated blood, which could lead to physiologic shunt. Okay, and then it goes to the left atria, left ventricle, right? So there is a pressure. So thinking about this, guys, if you put your catheter, let me see if I have that here. The doctor said, Manny, can you help me? Sure. I'm gonna float PA catheter. Do you know how to do it? Oh yeah. What do? Get your pressure bag. So some ICU, they have those 1 bag 3 pressure transducers, right? So you get your normal saline, depending on how active and your protocol. Some of the ICU, they only use 500. Some ICU, they use 1,000. So depending on what's your guidelines. So let's just say you use 500. So some nurses will poke the saline, like remove the seal, poke it and remove it. Make sure you keep the sterility, and you burp, right? You burp your saline, getting rid of the air, and then as you are burping it, you poke it again and keep it up, right? Keep it on there, right? And then you put your pressure bag, you inflate your pressure bag to 500 until 300 millimeters of mercury until you see that green. So the new nurse said, until I see the green, which is true. And then make sure you check your tubings, tighten it, because if you don't, the company, the factory, how they're putting them into the packaging, they're not very sealed or tight. So you have to tighten it, every part of the connection. And then you make sure you change those cups because they have holes in there, the white one. But you have, before you do that, you have to flush it first. So what your role is, you have to make sure that you have flushed the tubings, your transducer, the pressure bag is ready, right? And then you get your transducer, and then you zero them when you are connected to the catheter, because you just have it ready. Okay, so that's one thing that I want you to understand. The doctor is putting in PA catheter. So majority of the patient now, they put the PA catheter in OR, but sometimes they put it at the bedside also. And that is the frustrations of the doctor, because if no one knows how to assist them or assist them on how to float the PA catheter, then we have a problem. Why? Because your monitor, you need to change the window, right? You need to go like mode, just like on your cell phone. You need to go to the PA insertion mode. So if you don't know how to do that, you better ask your educator now if she knows or he knows. And then, or your charge nurse. And then once the doctor is putting in like a central line, he would then you know, make sure that you are connected so that you can see where is this catheter going. So if you see a CBP reading, you tell that, because some doctors don't be looking the monitor, you're the one who's in charge to be looking at the monitor. So he's threading it in like that, and then you said, okay, you are on the right atria, right? Then it will go down, and then you see this up and down, up down stroke, and but no dicrotic notch. That is your right ventricle. Then you say you are the right ventricle. He would then keep going, because you can't stay in right ventricle, or else it will give you premature ventricular contraction. It irritates the ventricle, right? So PVC. Then you see those dicrotic notch. Okay, if you see the dicrotic notch, that is your pulmonary artery pressure. So then you say you're in pulmonary artery. And then you see a wedge like a CBP again, from dicrotic notch to like CBP again. That is now your wedging. Before you do that, what I miss in the step is you are in the right atria, balloon up. You need to tell the doctor, if he forget CBP reading, right atria, you want to balloon up? Sure, balloon up, okay? So when you say balloon up, because you're holding the non-sterile anymore, you lock it, okay? So by just moving the red arrow like this, you lock the balloon so that it won't deflate. Why? Because so that you won't puncture the parts of the internal parts of the heart. So that's the reason why you're floating it, right? And then towards the end, on pulmonary artery, it will wedge. The doctor would then pull it back and said balloon down. When it's balloon down, it will be dicrotic knots. And then he said balloon up, you inflate again, hold, because it will advance, and then you will see a wedge again. That's how they are double checking if indeed that is the end part, right? That's the tip of the catheter. And then you will look how many measurement. So when you see a bar, a very solid bar like this on the catheter, like fat dark bar, that's 50. And then the small ones, light one, are 10. So 50, 60, 70, right? Let's say 70. Then you then say 70 centimeters. Okay. Then we're good. Then you secure it. Balloon down. Okay. You do not leave it on, or else it will infarct your pulmonary artery. So what happened here? When the balloon is up, you're wedging. That's the beautiful aspect of hemodynamics. In the normal state, the left atria contracts, relax. Left ventricle contracts, relax. Mitral valve open, close, right? When everything is relaxing, mitral valve opens. When the mitral valve opens, you see that pressure in the left ventricle transcending into the left atria and into the pulmonary vein, right? That is what we call the left ventricle end diastolic pressure. Left ventricle end diastolic pressure, LVEDP. So your wedge is also measuring the left ventricle end diastolic pressure. That is so beautiful there. So if your mitral valve is good, right, healthy, in the healthy individual. All right, well, I don't know if you understood what I just said, but you can always rewind it again, because that is really important to understand. And that's your wedge, right? So the wedge is what the monitor said, 8 to 12. Okay, your wedge here is 8 to 12. All right, so let's just go over CBP. 0 to, normally it's 0 to 4. Shouldn't have any pressure, so that the blood will just free flow back to the right atria. But in nursing, in ICU, 6 to 12, right? Especially they developed this during when sepsis, you know, they just want to make sure that we're in the safe side, we have enough volume. Do you trust CBP? No, a lot of the hospitals don't use CBP as an indicator for fluid because it's very inaccurate. It's just only telling us the upper portion, but what about the lower portion of the body, right? So again, depends on your hospital. And then your right ventricle, there's a pressure into the right atria and right ventricle, right? So sometimes it says 5 to 15, something like that. And then when they go to the pulmonary artery, we call it 15, 30, right? So 10 to 15 systolic, 20 to 30 diastolic. This is very important. Why? When your PAP, your pulmonary artery pressure, will go up, then there is a build up in front of, in the lungs, that the right ventricle is having a hard time to push, right? So that is your afterload into the right side. Right ventricle is pushing blood out of the heart into the lungs, but I'm having a hard time. What's going on with the lungs? That is your pulmonary vascular resistance. And very important, critical thinking. Why? Sometimes pulmonary edema, right? And we blame the heart for having pulmonary edema. So you need to isolate that. How? What we use is our wedge, right? Is your wedge normal? If my wedge is normal, 8 to 12, and my PAP, pulmonary artery pressure, is 30, let's just say 40 over 60. Woo! That's a high pressure there, right? Well, don't blame the heart. The heart is it's okay because the left ventricle, left atria is good. It can accommodate, it's compliant. However, your lungs is not, because I'm pushing, the right ventricle is pushing, but the lungs is not compliant. So that's the reason why in the middle, the pulmonary artery pressure is building up, the pressure. So then you say, this patient probably have a pulmonary hypertension, pulmonary embolism, right? Cor pulmonale, we don't know, or anything about the lungs, but not the heart. So don't blame the heart. However, if your PaOP is high, then that is a backflow pressure. So then there's a problem with the heart. So we call it a pulmonary edema with no cardiac involvement. It's just plain the lungs. Okay. All right. Then MI. Ooh, MI is really a nice topic, right? I like MI. When you get your CCRN or your PCCN, there's a lot of myocardial infarction. So in MI, you have those what we call acute left or acute right ventricular failure. And refractory pain, right? That Levin sign, when your patient is grabbing their chest, we call it Levin sign. Okay, Levin sign. So Levin sign. And then there is a significant hypotension or hypertension. So guys, if right ventricular infarction, right, the right ventricle infarcted for some, like let's say accident, please, when they become hypotensive, what I learned over the years is you have to fill up the tank. Okay, fluid challenge this patient. I know some nurses were like, oh no. Yes, just do more fluid resuscitation and see if it will correct the hypotension. Okay, if it's the right side, because the right side is the receiving chamber, it's okay. The left side can always eject it out, okay, or pump it out. So mechanical complication, if you have a papillary muscle rupture, how do I know? You have a peak T wave into your, like a CBP, into your PA wedge pressure, right? ACV, ACV, ACV. If you have a very peak V wave, so if your ACV, ACV, like an M. So if you have like an M into your PA wedge tracing, then there is that chance of papillary muscle rupture or interventricular septal rupture. Okay. Acute right ventricular failure after pulmonary embolism. If you have a valvular disease, aging valves, cardiac tamponade. With the cardiac tamponade, guys, I want you to pay attention because there's a lot of reasons why our patients are having cardiac tamponade, and the equalization of your PaOP. So your PaOP and your PAD, pulmonary artery diastole, right? So some hospitals said, well, we don't wedge, Manny. That's okay. Just use your PAD, let's say 15/30, right? So if you have this 15/30, well, that's still kind of normal, right? So this is the diastole. So some hospitals, they're using that in replace to your PaOP. Okay. However, if you are wedging, let's just say I wedge and it is 30. Well, 30 and 30, they equalizes in pressure. So sometimes that is a suspicion of cardiac tamponade. The last patient I had, well, not me, but I was a resource. and blood pressure is low, hypotensive, and CBP is 18, and then the PAP is kind of variables. So if you have that, your tank is full, CBP is high, blood pressure is low, and then you put your stethoscope and you will listen that distant heart sound, right? You don't hear like blub 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 blub. And then you look at your outline, like pulsus paradoxus, right? So what you can do is you suspect, especially if this patient has a cabbage, second day or first 24 hours. So then you do a chest x-ray. I know that's what the doctor wants. Do a chest x-ray to see if there's a widening mediastinum, and then check out your chest tube output, okay? And if your chest tube doesn't have any output or no drain at all, you suspect of cardiac tamponade. You do something. Try to make sure you check that chest tube, make sure that it's patent, right? And if your output is going down, for sure that you suspect that there is a clot in there, by any means do something on your power to unclog that. It will help you a lot. Reposition the patient. Some hospitals don't milk, but they milk but not stripping, right? Get your forceps, tap it, position the patient, like those kind of things. Ensure that there is an adequate drainage. So some of the hospitals now, they have that thing in their chest tube that they will just go in and then out, in, out, in, out to dislodge that clot, and then you see blood flowing. You pay attention, okay? So what did we learn? When you get an open heart patient, the first turn 200, that's normal. Don't worry about it. It's not bleeding. Those are the remnants, the residual from OR. On your second hour, when you turn the patient and you still have 150, that's abnormal, right? Because why is it 150 on that second hour? Because the first hour is fine with me because that came from OR, but the second hour is no longer normal, so you escalate. So that is your cabbage, but we're on MI. So that's MI, cardiac tamponade. Why? If you have an MI, this is your heart. I have an MI here. After 24 hours, it will soften that MI and start bleeding, right? So that is a part of your bleeding. That's the source of the blood that could accumulate into the sac, and that would then strangulate your heart. The heart cannot pump, right? There's a limitation of that space to move. So strangulation. So that is your cardiac tamponade. And then of course pulmonary edema, pulmonary hypertension, acute respiratory failure, ARDS, those kind of things. Okay, so this is your, as I've mentioned, when you're helping the doctor to put a PA catheter. So balloon up, CBP, balloon up, and then right ventricle, don't stay there, it will create PBC. So how do I know? Well, on your monitor, it will like this. There is that R wave. The R wave is widened on your V1. Okay, so I don't know if you guys are doing that, but I normally use V1 or V6 when they are inserting a catheter, so that you can see. Your 2 is good for the R wave on lead 2. Your V1 and your V6 is good on your R wave when you're suspecting of your ST segment elevation or depression. And then pulmonary artery with a dichrotic notch, and then your wedge. Okay, so that is your PA catheter. So have you guys seen this? Oh yeah, you're right. The systolic is higher. I'm sorry. Your pulmonary artery systolic is higher. What did I say? 15? It was inverted it. The systolic is 15. Okay? Sorry. You know, that's the thing. You know, my brain, how it works. But hey, if I brought somebody with me, then that's two brain, right? And then they will tell me, Manny, you're wrong. But you know, to me, if I see this, it will go back. So I always look at those numbers. Okay, what did I say? Your PAD, pulmonary artery diastole, is your in lieu of your PAOP if you do not wedge, right? If the hospital said, we don't wedge, sorry, because we don't want you to have a pulmonary artery rupture. Okay, that's fine. Because sometimes, yeah, that happens. Some nurses, they have like when they wedge, or even some doctors, when they wedge, the balloon will pop. So there is the technique. You push that syringe slowly but consistent. You do not stop. You slowly push consistently. And then your CBP is here too. Okay, normally this is your art line, heart rate, art line, PAP, CBP, right? And saturation. So still in the vascular system, your arteries supply blood, nutrients, hormones to the tissue and remove metabolic waste from the tissue. Resistance to flow, again the Poiseuille formula. The length of the vessels, of course, if it's too long, the pressure towards the end is lower. The radius, of course, if it's too big, the pressure is low. If it's smaller, the pressure is high. Viscosity of the blood, if it's thinner, then it's higher pressure. If it's very viscous, it's kind of hard to push, right? Higher pressure. Components of the vascular system, your arteries, arterioles, capillary, vein, and blood pressure. So this is your capillary bed. Is the nutrients bed where exchange of gases, right? So you have hydrostatic, capillary, colloidal, oncotic pressure, pressure pushing fluid, and then edema is caused by the imbalance of this pressure. So that's just an FYI. Okay, your venous system is the return system that brings the oxygenated blood. So SVO2. So if the doctor said, hey Manny, can you get me an SVO2? You only do an SVO2 on the PA catheter, pulmonary artery catheter, because it's go all the way to the pulmonary artery, right? But SCVO2 is central line. So that is the above the superior vena cava, like 2 inches above the right atria. So that is your SCVO2. So 60 to 80. So you want your SCVO2 or SVO2 to be 60 to 80. That's your normal. If it's low, you suspect that your tissue, at the tissue level, they're hungry for oxygen. Why did they eat so much and the return is so low? Pay attention. Okay. Do you need blood transfusion? Check the hemoglobin, hematocrit. Check the hematocrit level. You might need some blood transfusion there, or just fluids. Okay, so now we're entering hemodynamics. So I've said the CBP is your cardiac cycle, right? Cardiac cycle. So do you guys understand the cardiac cycle? So if the atria contracts, right? Atria contracts, that is your A. When the atria contracts and it emptied the blood, then the blood are all in the ventricle. And then when the ventricle will increase in pressure higher than the atria, it will closes the mitral valve and tricuspid valve, and it will contract in a closed container, right? So that is isovolumetric contraction. So when it contracts, it pushes the valves to close, and that is your C. Okay, so that C is the closure of your valves. And then when the ventricles is higher pressure than the aortic valve or the aortic valves open, and the blood will gush out strongly into the aorta, and then the aorta will expand, and that is your X descent, because there's a flow of blood. All of a sudden you're emptying your ventricle, right? However, while it's doing that, the right atria, the left atria will become, and the right atria, they will become a tank, right? It fills in blood from the superior inferior vena cava, from the pulmonary vein, from the lungs. So it become like a tank waiting to be filled. And then when that atria it's filled with blood, right? So the pressure now is higher than the ventricle. Well, it's not higher yet. It's a little bit, it's building up, but the ventricle is pressure, it's still higher than the atria, so the valves are still open or closed. However, if the aorta is higher pressure than the ventricle, aortic valve, pulmonic valve closes, right? So when it closes, then that is what you call the V, right? No, the S2, I should say. So when the aortic valve, mitral valve, tricuspid valve, again, let's repeat. Left ventricle, right ventricle pressure is higher than the aorta, the atria, right and left atria. Those tricuspid valve, mitral valve close, that is your S1. The closure of your mitral and your tricuspid valve, S1. Then, and that is your C, right, on your CBP. X, descent, blood out of the ventricle. Aorta, high pressure, 81. Ventricle, pressure, 80. Aortic valve closed. Pulmonic valve closed. And that is your S2. Then, the atria is continues to collect blood, right? Then it's too heavy. What happened is it will passively open the mitral valve. The blood flows. That is the passive ventricular filling. What happened there is the atria now is still there trying to collect blood. However, the mitral valve is open. Blood now is free flowing from the pulmonary vein to the left ventricle. That's what we call diastasis, right? Diastasis. And then atria then will start to contract, and that is your active ventricular filling. and that is your V wave. Okay, so the V is when the atria filling up. The Y is when there is a passive opening of the mitral valve and passive ventricular filling, and then it will contract again and it goes back to A. Okay, so that is your cardiac cycle. Oh my God, what did you learn there? Did I make you confused? Well, hopefully not. Okay, because as I've mentioned, your A is your atrial contraction. Your C is going to be the closure of your valves, and of course that extra hump because the ventricle is starting to contract and there's an early ventricular contraction, so closure and early ventricular contraction, and like an isovolumetric contraction, and then opens up the aortic valve, blood gushes out from the ventricle, it empties the ventricle, right? So that's why it went down. There's no pressure, it dipped down, and then the aorta is filling up again, right, with blood, and that's when the pressure builds up again. So that is your CBP. That's why it's important to see your V wave if it's very peak and elevated, because that's the cardiac tamponade, right? That's feeling, that's the feeling pressure. Feeling pressure, feeling pressure, fill up. So again guys, this is your CBP tracing. So CBP, see this one? This is the one that I told you to measure. If this is 0, so let's say that's 10, and then the lowest one is 5, so CBP of 5. Okay. The C point technique is you use it if your patient has AFib. C point, the top, and then the lowest one, right? The lowest one, and then the middle. So that is your C method, C point technique. All right, well, it's going to be a very long hemodynamics. That's the reason why I don't know how many educators are teaching this, and some of the nurses will fall asleep while having this, classes. So don't. I highly recommend for you to keep watching and keep listening. If your patient is vented, you will only read your CBP V, vent, valley. When it deep, when the patient exhalation is the valley, because sometimes like that, right, like that, and then it goes down. So that's the valley. Mechanical ventilation, valley. If the patient is spontaneous ventilating, like no vent, then peak. During exhalation on the peak, like like whatever the highest point, that's your peak. All right, so that's a tip. Don't forget that. Okay. All right. So the more accurate that you're reading your CBP, the more you're addressing the fluid status of your patient. So fling, if your patient has a PA catheter and you see the Burj Khalifa, the hotel in Dubai, it looks like this, right? So there is that two kind of dichrotic notches. Well, your catheter is too far out, too far in. So turn your patient to their left. So we just ask them, or help me, can I turn the patient to the left? So hopefully it will reposition. Okay. Excessive catheter length. Turn the patient to the left side. Air bubbles within the pressure monitoring. So one of the contraindication of PA catheter is if you don't know what to do with it. If the clinicians are incompetent, it's a contraindication of putting a PA catheter, because you don't want to get this patient infection, complication, right? So air bubbles within the pressure monitor, or there are some fibrin at the tip of the catheter. What do? Well, flush. That's the reason why we flush it. You know, you you flush it depending on what is your protocol. Some of the hospitals are every 2 hours, every hour. Okay, you have a large A-wave, mitral stenosis, severe aortic stenosis, hypertension, AB block, and AB synchrony. You know, you should understand what are those stenosis and the reason why they become stenosis. I might make some video about that because it's really important, especially for CV nurses. You know, open heart nurses, you should understand how it happens. So use the measurement of the A wave for the PAOP, right? Because the mitral valve is open during the A wave. Mitral regurgitation, cardiac tamponade, constrictive pericarditis, hypervolemia, left ventricular failure. If you have a very high A wave. However, if you see 2 on your EKG, there is this 2P wave, right? Well, I'm talking about the EKG now here. I'm not talking about the CBP. That is core pulmonal, P mitral, right? So we call it P mitral. Patient who have a core pulmonale, that's the reason why they have the P mitral, like 2P waves in the EKG. But if your CVP is like this, like an M again, high A wave and V wave, think about cardiac tamponade, constrictive pericarditis. So preload, CBP on the right side, PAOP on the left side. Again, CBP on the right side, PAOP on the left side. Wedge. Why, Manny? Well, superior, inferior vena cava, right ventricle before the heart. Remember, right ventricle left the blood to the pulmonary, to the lungs. Now they're going back to the left side. That is your PAOP. It came out of the heart. It went to the lungs. So that's why before the heart. Preload before the heart. Afterload after the heart. So your right ventricle to the lungs. So outside, right after. Left ventricle to the aortic valve. Right, left side. So right side is PVR, left side is SVR. Right side is PVR, left side is SVR. Right preload is CBP, left preload is wedge or PAOP. Contractility, your right ventricular contractility is your right ventricular stroke work index, and then your left ventricular stroke work index. Do we use this? Yeah, we do use it when you have your hemisphere, right? Because this is just your contractility. Some doctors like to know this. So these are your magic numbers: CBP 2 to 6, 6 to 12 sometimes, PAOP 15 to 30 systolic, 5 to 15 diastolic. That was my mistake a while ago. I come corrected. Sorry about that. Then your mean is 10 to 20. Your cardiac output is 4 to 8. And your cardiac index is 2.5 to 4. magic number 2.5 to 4, PaOP 8 to 12, SVR 900 to 1400, and then PVR is 100 to 250. Okay. All right. Well, let's just kind of, you know, this thing, guys, there's a lot of information here, but let's just go over. So if you have a high SVR, which is your 800 to 1200 or 900 to 1400, so let's just say 1800, right? So that is very tight. Too high, too tight. Too loose, too low, too loose. So if the highest the number, the tight it is. The lowest the number, the loose, the dilated it is. So when you have a high SVR, hypertension, low SVR, sepsis because of the vasodilation or arteriodilation, right? Anaphylaxis, high cardiac output, hyperthyroidism. If your cardiac output is 4 to 8 and you have 20, well, that's hyperthyroidism there. So that is what we call a normal cardiac output heart failure, right? Because they are too dilated and they heart fail. And if you have a low cardiac output, you probably have some MI or tachydysrhythmia. Remember, guys, if your heart rate is fast, do you think there is a time to refill? No, right? So that's why tachydysrhythmias is no time to refill blood, to squeeze, refill, squeeze, refill, squeeze, refill, squeeze, right? So that's when your blood pressure goes down. So cardiac output goes down. High CBP, too much fluid. Your tricuspid is dysfunction. Your right ventricle is failing. Your pulmonary artery are having stenosis, not patent. You have a pulmonary hypertension. You have positive pressure ventilation, that increase in intrathoracic pressure. You have a cardiac tamponade, or you just have a chronic left ventricular failure. There is a backflow, right? The forward flow is poor, then it will backflow. What happens if you have a very low CBP? You're dry. Low CBP, you're dry. Or you're too much vasodilate. Instead of this, your arteries are like this, but they're like this. Too much, right? Too dilated. Of course, the blood is not enough if it's too dilated. Then, vasodilation from septic shock, anaphylactic shock, or neurogenic shock, you know, because of the histamine. There is a histamine release into the endothelial cells and into the, into the arteries that dilates, or your vessels that really dilates. So pulmonary artery pressure, remember I told you about this a while ago? If it's going up, like what is the normal? 30/15, right? There is a ventricular septal defect, left to right shunt. The blood is flowing back to the right side from the left. Pulmonary hypertension, there is a constriction, right? So the beauty of the pulmonary is, let me tell you guys. So zone 1, zone 2, zone 3, right? So technically what we called is pulmonary artery recruitment. or pulmonary capillary recruitment. So if you are not using them, they're fine, they are closed. But if you are exercising and you are cardiac output goes up because you're exercising, the flow of blood will increase, right? And they start recruiting capillaries to open up. So the more capillaries, then the more blood flow happening into the pulmonary system. And that's the beauty of your pulmonary system, respiratory system, right? There is the capability of pulmonary capillary recruitment so that the flow is increasing. And then your zone will then, move. Let's say your zone 0 is not working, your zone 1 is not working, zone 2 is not working, zone 3 is only the one that's working, then zone 2 will work and zone 1 will also work. Then there is a movement of ventilation and perfusion ratio. Okay, your VQ, ventilation, perfusion. Okay. So what happened? Mitral valve regurgitation, constrictive pericarditis, cardiac tamponade again, left ventricular failure if your PAP is high. However, you guys be very careful because you need to have your PaOP elevated here too, right? So don't blame the heart if it's not the one causing it to increase. So again, you will only add their names here if their P wedge is really high. But if the wedge is normal, they're not to be blamed. Okay. What about if you have PAP low, hypovolemia, dry, excessive vasodilation, such as septic shock, anaphylactic shock? Okay. So there's only two things that you can think of: constriction, dilation, constriction, dilation, constriction, dilation. Right? Dry or wet? Dry or wet? Okay. So dry, dilate. Same. Cardiac output, when you're having some stress or exercise, it will go up. That's why there is what we call the catecholamines release, catecholamine storm, right? So catecholamines, you guys know what catecholamines is? Okay, well, there is the dopaminergic, right? The dopamine releasing, it become norepinephrine, and then it become epinephrine by your body. Especially when you're eating a lot of protein, there's a protein synthesis, right? Those amino acids, things like that. All right, and then the exogenous catecholamines, your epinephrine, other inotropes, your whatever we give to our patient, your digitalis, infection, early sepsis, and hyperthyroidism. These are actually, so when you're when you're have some infection, right? Of course, that's your body releasing those, fighting for that toxin. So there is what we call the effect on that, increasing your cardiac output. Then what about decreased cardiac output? So your contractility is low. Why? Well, the pump is not working, so your MI. Or you have some sort of like a cardiomyopathy. So what is a cardiomyopathy? So there are 3 types of cardiomyopathy, right? But the most thing that I want you guys to understand is, if this, let's just say, I'm gonna illustrate the left side of the heart. So this is your right atria, and this is your mitral valve here, and this is your left atria, left ventricle. Did I say right atria? So left atria, mitral valve, and then septum here, right? So what happened with the hypertrophic cardiomyopathy is, if your septum is so thick, right? So let's just say this is your septum, and this is your aortic valve, right? So this is your aortic valve. So when it contracts, when I contract, the left ventricle and the right ventricle contracts, so the septum is becoming obstructing the flow because of the septum. So the blood will having a hard time coming out of the ventricle to the aortic valve because of the septum. That is your hypertrophic obstructive cardiomyopathy, HOCM. Not good. A lot of people dies because of that. Okay, your SVR, systemic vascular resistance. You know, this video is really getting longer now. I think I'm just gonna stop on the hemodynamics so that we have more opportunity for the other system. So what we're talking now is you have an MI patient that went to OR or cath lab and then came back. They said the stent is not working, so we're just gonna take him to operating room for CABG, open heart, 2 valves, right? So now they're coming out to your ICU, CV ICU. Now you're gonna take care of this patient. You're gonna recover an open heart patient. So this is what we're talking now, is you need to have an understanding of hemodynamics. Or let's just say my patient is an ICU, regular ICU. I just want to know what are the hemodynamics. But this patient has a heart failure, right? Pulmonary edema. So the doctor put in a PA catheter. So that's why we are now studying and learning hemodynamics. So what did we learn so far? Your preload, blood before the heart. Are you wet? Are you dry? How do I know? Look at your CBP on the right side. Look at your PAOP on the left side. You can only do PAOP or wedge if you have a pulmonary artery catheter, or what we call Swan-Ganz for those nurses who don't know what's PA catheter. Do you trust your CBP? Just use it, but a lot of literature and research out there says it's not accurate, right? But if you have the number, then use that number. And then afterload, outside the heart. So what's on the outside the heart? The right side is the lungs, the left side is the peripheral circulatory system, right? Your systemic. What happened? If your PAP, pulmonary artery pressure, is high, that is, pulmonary artery pressure means the lungs is having problem. SVR is high, then the pipes, the vessels out there, total peripheral resistance is high, is tight, right? High, then that is your afterload. So the higher the number, the tighter the pipes. The lower the number, then the loose or dilated. Okay, so that's what we were trying to understand here. So now we go with SVR. So when your number is high in SVR, so the normal is 800 to 1200, some books are 900 to 1400, but let's just say you have a 1800 dynes SVR. Ooh, that is really high, right? So it is a compensatory mechanism for what reason? If your cardiac output is low, that is a low blood pressure, your body will say, hey, something's not right. They will release renin, angiotensin, aldosterone system, your RAS. They will release a lot of those, baroreceptor, chemoreceptors to constrict. And of course, if they are constricting your alpha-1 into the arterioles, then your SVR will then go up. Okay? So If your mean arterial pressure is more than 65, that's what we want, because there is a built-in pressure to overcome to get into the capillaries, right? So let's say outside my heart, there is arteries that goes to my brain to feed, you know, oxygenated blood to my brain, but there are built-in pressure for you to penetrate to go to that route. There will be pressure built in to go to my kidneys. That's a high pressure because you have your efferent and afferent. So you need to have at least 50 millimeters of mercury pressure. Would you imagine if my MAP is only 45? Those kidneys will not gonna get perfused because they have about 50 millimeters of mercury there. You need to have at least 55 to perfuse my kidney. If your MAP is only 45, my pressure in my kidneys is higher. Sorry, my kidneys will just then die. Acute tubular necrosis, or ATN, right? So that is the main reason why the doctors want you to keep your mean arterial pressure above 60 or 65. I would recommend 65. So you go for your mean arterial pressure. I hope you guys understand that, because that's really important. A lot of the patients in the ICU, if their blood pressure has been sitting really low, they eventually get dialysis, and then the nurse would say, why? No, you killed that kidneys, because the kidneys are very, very sensitive with pressure. They need constant perfusion, blood perfusion, right? Oxygenated blood, and they can only penetrate the pressure if you have more than 50. So that's why we want your blood pressure to go up, mean arterial pressure to go up. So what happened why they increase? There is a volume infusion, peripheral vasoconstriction, your low cardiac output states because it's compensatory mechanism, hypothermia, viscosity of your blood, hypovolemia. So when you're dry, it will concentrate on squeezing more. When you're dry, they're trying to prevent from releasing more fluids, so there's vasoconstriction, right? All right. Or you have too much pressors, like your Libofed, your vasopressin, you know, those kind of things. Go slow. Nitro. Go with your nitro. Nitro is really good. And then what if it's too low? So too low, too loose. So you're giving me diuretics. Now I'm dry. You're giving me vasodilator. So what are your vasodilator? Nitroprusside, nitroglycerin, hydralazine, right? Or I'm in a hyperdynamic state of sepsis, and peripheral vasodilation from infection, septic shock, things like that, or loss of vasomotor tone, neurogenic shock. Okay, so these are the reason why you have a low SVR. In my practice, I hear the doctor complain. They would say, hey, why are you calling for SBR, right? High SBR, when you know that I think this is the problem. So the nurse is going up with the nitro drip when the cardiac output is low. So her focus and attention is more of the SVR than the cardiac output, cardiac index. It's a no-no. You have to go with your cardiac output or cardiac index first, and then deal with your SVR later. So that SVR is not your priority. It's a compensatory state. Cardiac output, cardiac index is your priority. Because technically, if your body feels like you have a low blood pressure, they will clamp. You will constrict. So why are you going up with your vasodilation, right? Why are you going up with your nitroprusside when the reason being is not the SVR, it's the cardiac output, cardiac index? So that's what we call critical thinking. If you're dry, your SVR is gonna go up. Check your CBP, check your patient, check your hemodynamics, cardiac output, cardiac index before your SVR. What about your PVR? If it's too high, pulmonary hypertension, right? Give them Viagra or Flolan. Pulmonary edema, pulmonary emboli, high PEEP, sepsis. If you have a low, this is not SVR, this is PVR. You have a vasodilator like prostaglandin, and you're trying to correct your hypoxia. Okay, so high PVR, pulmonary hypertension, how are you going to manage it? Flolan, Viagra. Or you have pulmonary edema, how do you manage it? Drain, Lasix, things like that. Low PVR, your vasodilator, you're vasodilating. So you have prostaglandin, too much prostaglandin, your body is correcting hypoxic event, so you're having some pulmonary capillary recruitment. All right, and I think that's it, guys. So this is just how to manage. So if you have a very high CBP, to decrease it, you just have to not give them fluids, or you give them Lasix. You give them morphine if they're in pain. It's really very good vasodilator. Nitro. So I love nitro because it's both venous vasodilator and arterial vasodilator. So it's really good. How are you going to increase your CBP? You're going to give albumin, hetastarts, dextran. I'll be very careful with your dextran or hetastarts. It's actually giving your patient pulmonary edema or bleeding sometimes. Check their H&H. If their H&H is low, it's also one way to help them with their volume, blood transfusion. What about if you have a very low PVR or SVR? So to increase vasopressor, phenylephrine, norepi, right? These are your low blood pressure. Dopamine, vasopressin. When you have a very high SVR, high blood pressure, you give them vasodilator, nitroprusside, nitroglycerin, hydralazine, balloon pump, right? For PVR is Flolan, nitric oxide. I have a nurse. She kind of mixed up her Libofed. So the blood pressure was going up, like 170 over 90, and then and then she was going up with her Libofed. She kind of mixed it up. So no, you have to turn off your Libofed, because Libofed, norepinephrine, is used when your blood pressure is low, right? So go up. So I feel bad for her. The managers are so mean. They wrote her up, and because she doesn't know what she doesn't know, or she kind of probably mixed it up. She got confused. So I would recommend get you somebody, brainstorm, consult your charge nurse, consult other nurses, because I know a lot of ICU nurses are very smart, especially the season one, if they've been a nurse for a while. Oh, but then they said years of nursing in the ICU doesn't really correlate with the amount of knowledge and experience you have. Because what if, I've been a nurse for 33 years, what if I just work in the community hospital that doesn't have balloon pump, Impella, CV surgery, EVD, that they only take care of basic ICU, right? So if they go to the higher acuity ICU, they probably don't know what they don't know also. So that's why. Okay. So what about your contractility? If you're high left ventricular stroke work index or right ventricular stroke work index, so to decrease it is beta blockade, calcium channel blockers. Well, to increase it because your heart rate is slow is digoxin, dobutamine, right? Or PDE, milrinone. So if you're not familiar with those, review those. Those are pharmacology, so that you are able to use them at the bedside. So you have vasodilators and you have your vasoconstrictors. That's why I like about ICU. You have everything at the bedside. Vasodilate, vasoconstrict, right? Balloon pump, impella. If your cardiac output is really low and your contractility, your heart is hypokinesia, hypodynamic, right? It's not strong. Then let it rest. Put a balloon pump, put an impella. So, how to decrease your heart rate? Procainamide, antiarrhythmics or dysrhythmia, amiodarone, calcium channel blockade, adenosine, right, to break the SVT, vagal maneuvers, cardioversion if they're symptomatic. If they have epicardial wires, overdrive pacing. If they go code blue, defibrillate. How to increase your heart rate? Well, atropine. You know, your patient will go south faster if their heart rate is low. They will like, whoop. So, and then how soon can you get atropine at the bedside? From your fixes, right? And then they told you, do not override. Oh my God. So this is something that you guys think about. In the event that your patient is slowing down to like vasovagal and sinus bradycardia, you see they're gonna turn pale, white, and then they pass out. What do you do next, right? So if you get your atropine good, you give it, and if you're not, then you get your transcutaneous pacemaker, right? Your Zoll, or whatever machine you have, and then epinephrine or pacemaker. Your SVO2, as I mentioned a while ago, is really important. However, we have the there was a situation wherein SVO2 will come back normal even on a sepsis patient, septic shock patient, and they call it a not very accurate, and because you know your cells are not utilizing oxygen appropriately, so that's what we call cytopathic hypoxia or cytopathic hypoxia, because the machine, the SVO2 is coming back normal. And so some of the doctors, like smart doctors, would not use SVO2 as an indicator of your tissue perfusion, because there is such a thing, right? Cytopathic hypoxia. Okay, well, let's move on. So blood leaves the left heart 100% saturated. Oh, we talk about this physiologic shock. So complication of your PA catheter, arrhythmias, a lot of VBCs, hemorrhage, ruptured, infection if you don't take care of it, thrombi if you guys are not flushing it, emboli if you're pushing too much air, pneumothorax if you puncture the lungs, cardiac perforation, again if you ruptured it, pulmonary infarction, balloon inflated, left inflated, and vascular occlusion or spasm, you know, whatever you're using, and entry point. Balloon is deflated after obtaining wedge pressure to prevent pulmonary infarction, so that's why we always make sure you check. Catheter is inserted under sterile technique, so when you're assisting the doctor, you have to really take care of your catheter. Where I had, you know, your central line protocol, right? Central line insertion protocol and guidelines. Pressurized bag is maintained at 300 millimeters per mercury, and electrical equipment is well grounded and operating correctly. All right, so condition, If you have a cardiogenic shock, you will see a increase CBP, increase right atrial pressure because the heart cannot pump effectively, so there is a backflow, and then your SVR because it's low cardiac output and cardiac index. So cardiogenic shock. Okay, the compensatory mechanism is high, but your cardiac output and cardiac index is low. Hypovolemia is all low except SVR high, right? Again, it's compensatory mechanism. Anaphylactic, they're all low because of the vasodilation from diphenhydramine, right? Diphenhydramine. Histamine. Oh my God, my brain. Not diphenhydramine, but the histamine release into the system, into the vessels. Neurogenic shock is the same. There is a neurological impairment. There's no more communication, right? So they're not going to respond to anything. So everything is low. So early septic shock, early is natural. It's like kind of normal. Cardiac output is still okay because it's starting to vasodilate and the pipes are good, but the tank is still good. So it appears to be like a lot normal. So you have a low SBR, low right atrial pressure. You're kind of dry a little bit, but your cardiac output is good. And then septic shock late, then everything goes down except your SVR as compensatory mechanism. So your cardiac index, as I mentioned a while ago, you really have to pay attention. So this is what I have been using for many years. If my patient cardiac index is 2.5, 2.4, I have to make sure that I watch this patient because subtle changes is actually going to tell you something is not right, right? So a 75-year-old female, she was very alert orientated when I got her. And then like after she ate breakfast, because I guess the food is now asking for more blood into the gut and then there's no more blood supply into the brain, right? Your CPP, cerebral perfusion pressure diminished. So then she became a little bit more disoriented, restless, and confused. So I thought at first, is she having some stroke, right? But I picked up right away. So, you know, things like that, subtle changes. And if you are that nurse who I told you seeing hypotension, anuria, lethargy, coma, cold blue, right? Shock, that is all towards the end, right? So you are seeing this and there's so many things already going on. So please try to really monitor your patient, practice critical thinking. And how do you do that? Check your patient, assess your patient. That's why you're an ICU nurse. As much as you can, right? Every 5 minutes, every 15 minutes, that's fine. That's why you really need to have a organized, you know, so you should be giving your medication, doing your assessment, so that you're not gonna get tied up to one task and then you forgot everything and then you neglect your other patient. Oh, you know, so I think it's just your organizational skills and your prioritization. And you guys know what's passive leg raise. If your patient is hypotensive, before you call the doctor, and if you don't have those cheetah, you know, like they call it the bioreactance machine. You put it here, you put it here, and then you do your PLR, and then you press the machine, and then it's gonna give you a stroke volume index. If it's less than 10, the patient is not responsive. If it's more than 10%, the patient will be responsive, fluid responsive. Same way. So your passive leg raise, you put your patient, you know, whatever blood pressure, right? Flat blood pressure. Then you elevate their legs like that. then you recheck blood pressure. And if the blood pressure went up, then all the blood to the brain, to the heart went back. Oh, all the blood from the legs went back to the brain and to the heart. Blood pressure went up. So they are at least still fluid responsive. So that is your passive leg raise. Okay? Let's see. All right. So what's wrong with these numbers? Okay. CBP low, right? PaOP is kind of 8 to 12, a little bit low, so she's really dry, or this patient is dry. 1100, so 800, 900 to 1400, so still good. PVR 100 to 250, so still good. So it's just being dry, right? So give him fluids. Alright guys, I think that's the end of my hemodynamics and cardiovascular assessment in the beginning, and more topics to come. I really thank you for your time. It's just me sharing information, and if you need your educator, or you need to go to a formal classes, do it, because it will help you with a lot of information that you would use and need at the bedside. All right, thank you guys, and have a great day.